Hi, Zoe. Disclaimer, I am a doctor, but I am not your doctor. In this conversation, we are talking about advanced care planning and end-of-life decisions. And it's important that you know that what you hear me talk about is frustrations with my experiences and personal preferences, but they are in no way medical recommendations or prescriptions for you and your family, because I don't know you and your family and your circumstances. So just take this as a little primer on the healthcare system that's coming for us all. So I'm trying this thing where I sleep on a big decision and I'll just say yes, even though I've been threatening to get a cat for a long time now, and Andrew's mouse traps have sufficiently failed.
Yeah, you still have mice.
Yeah. My patient needs to get rid of her cat because he's a tripping hazard for my cute little old lady, and he sounds so sweet, and the only other option was the daughter was going to take him to the shelter, and I was like, you know what? The mouse have been menacing me this week, including this morning when it ran across the dining room floor.
Oh. Well, he only did put the trap in the kitchen on the island. I feel like it's not going to be super accessible to any other mouse in the rest of the house.
He did go around the house and try to fill up the holes, but there's got to be mice living in the walls.
They're very smart. Yeah. They're already in the house.
So, and he sounds like a very nice cat. He was purring at the vet the other day. So I'm going to take him. The deal is he's not permanent. So unless I could change Andrew's mind, I also don't know that he'll be a good fit. But I can rehome him either to you. So I'll send you a lot of videos. He might be perfect for you.
Yeah, I did. As I was falling asleep last night, I was thinking about where would I put the litter box? What would I ask my landlord?
Because he's very friendly, and I think he might need someone during the day. If I were to get a permanent cat, I get a sassy, older, fat female. But he seems like a playful kind of cat that'll keep you company. Otherwise, I'll just see the barn people if they want a cat.
Yeah, you'll find someone to take him. This is exciting. Yeah, I would need to see pictures anyway before I make a decision about taking someone into my life like that. But you're getting a cat!
How is New Mexico?
Real old Mexico.
Oh, not old Mexico. Sorry.
Oh, it was really fun, but I was just thinking this morning, why is it so hard to wake up for this? This is not even that early, and it's because in Mexico we were staying up late every night, and we weren't eating dinner until 9 p.m., and that was 9 p.m. Mexico time, which is an hour different from here, so it was really 10 p.m. Yeah, so I just totally wrecked my sleep schedule, but it was really fun. Oh my god, I've had more good tacos than I've had in, I don't know, my whole life. So, not surprising. It was really cute.
Oh, what's in your mug? Is it tea or coffee?
Matcha.
Oh, okay. Which matcha do you get?
I just got the one from Costco, giant bag. It gets the job done.
Do you do water or milk?
Milk.
Okay, good.
Yeah, we're going for tasty here.
I like the Trader Joe's matcha. It definitely has sugar in it, which is probably why it's good. I have one from Whole Foods, which doesn't, and it wasn't really cutting it for me.
Yeah, I do when you come next, I'll make you some. I do the powder. I do a big scoop of the powder and then just milk and no water, nothing else. And it winds up making it really creamy. And I think that balances the grassiness.
That's what I'm looking for, you know? All right, so I think we've sufficiently talked our way into this episode. So welcome to Aftermash, the podcast where we dissect what life really looks like beyond the bounds of the loose leaf paper. I'm Zoe. As you can see by the fact that I'm wearing my glasses, I'm today's host.
Oh, she wears her glasses, everybody.
And we're joined by Jackie, my college bestie.
Hello. I'm just along for the ride today.
Oh, it's going to be quite a ride. I'm really going to make you feel vulnerable. I apologize. But any question I ask, you can throw back at me, okay?
Okay, good. I'm glad I'm already drinking my caffeine.
So I'm going to share my screen. All right, so we're starting with the ever-wise Dr. House.
I just want to die with a little dignity.
There's no such thing. Our bodies break down. Sometimes when we're 90, sometimes before we're even born. But it always happens, and there's never any dignity. I don't care if you can walk, see, wipe your own ass. It's always ugly. Always. You can live with dignity. We can't die with it.
So based on that and today's mash board, Jackie, what are you thinking?
Well, on our mash board, we have somebody who lives in a house. They have 2 kids, and they have both a dog and a horse. I wonder who we're channeling right now, Zoe. But they also have the values of not being a burden, and they have advanced directives of CPR, intubate, and blood transfusion, but not dialysis and a feeding tube. This person might be losing out on their value of not being a burden because they're reaching the point in their life where they are requiring a lot of care, and they need to figure out what care they want.
I would say that's very well said. We are going to talk about advanced care planning today. I have a few questions for you to start. You were a lifeguard, so you obviously learned CPR at one point. Do you remember learning CPR in high school, like before the lifeguarding started? Because it's like a formative memory to me for some reason.
I don't know if I ever learned it outside of lifeguarding.
Okay. I vividly remember having like to rotate through the scenes in the gym and being like, stop, call 911, environment is safe. And at that point, we were still learning mouth to mouth, which is not anything I have learned in my recent advanced cardiac life-saving certifications. But yeah, it was formative for me, which probably just speaks to my psyche as opposed to Jackie's.
You did go on to be a doctor, and I didn't.
It's also reading very fucked up novels as a kid. Now we get a little more serious. What interactions have you had with healthcare at this point between you and or your family? Either outpatient, but more specifically, like being admitted to the hospital. I know we talked about like your interactions with the fertility clinics, which are kind of like fringe medicine, but anything more substantial than that? It's not fringe medicine. They're just like, they operate differently.
Yeah, it's not exactly what we're talking about today. I don't know that I personally have had a ton. Like, nobody in my family's broken bones. My parents aren't old enough to be falling and not being able to get up. I think the closest that I can think of is, like, my grandfather, when he was alive, he had cancer, and so we would go visit him, and he'd be in the hospital, and he was always driving up from the suburb of Boston that they live in up into Boston to get his treatment. So that was the most hospital exposure I've had in my life. But I was like, 2 steps removed, so not paying a lot of attention to it. And I think since then, like, my family has gone to a lot of doctors, but I think that's different than what you're asking of, like, being like held overnight in a hospital sort of thing.
Okay. Have you, as the oldest child upon whom these conversations, and I assume the care of your parents when they become elderly, have you had any conversations about like what happens if they get like really sick or incapacitated?
No, the farthest we've gotten down that rabbit hole is them telling me that they've added me to they've like updated their will. And, but I think, at least in my family, my parents had me when they were, in their mid to late 20s. Their parents had them when they were in their early 20s. And so, like, my grandparents right now or my remaining grandmothers are in their 80s still. And so I think that conversation is happening predominantly at that generation level and not at my parents' generation yet. But to your point, life can happen, and we should still have an idea of what everybody wants, even if we're hoping that my parents are still like a few decades away from needing to use this information. I think we should still have these conversations.
Yeah. And I don't want to give any air superiority. Like, I know that my parents' healthcare decisions will fall on me as the doctor, whereas all the contracts will fall on my sister as the lawyer who likes contracts. However, they want to give me a few more years of training, so I have not actually had these conversations with my parents. And then I guess my fourth and final question, you kind of alluded to, do you frequently think about how at literally any moment, like, your life could change, your parents' life could change, in like a devastating health kind of way, not like they win the lottery, in case that's not clear?
Every day I wake up hoping they win the lottery. I do not think about that much for Any listeners who are not familiar with this, my sister has long COVID and currently lives with my parents. And so I think that's the element that I've thought about the most of like, she's been living there for 2 years. Will she still be there in 10 years? What will happen when my parents do need that kind of care? Will she also need that level of care? Like, what's like the long-term exit strategy for everybody involved in that situation? So I think I have thought about it from that angle. I don't know. Now that my parents are 60-ish, I'm definitely seeing them getting older, but I'm still like in denial that 60 is old enough that we should be having these conversations.
What a privilege. My dad was 45 when I was born. My mom was 40. So they are older. My dad is 77. And as you said, the conversations are happening at like the next level up. Like our parents taking care of their parents, even though my parents' parents are dead now. And my parents are the age of my patients. And so when I'm having these conversations, I'm having them about people who are the age of my parents with children who are 20 years older than me. And so I do get scared because like that could very easily be my parents one day. My dad's in good health. My mom is disabled, but somehow also in good health. They still live alone. Fortunately, they have enough means to probably die at home if they want. But it is something that scares me, and it just like, I get more bitter by the time, by no fault of anyone, that I lost with them just at default, like 10, 20 years. I also think about the fact that my husband drives to and from Boston many times, like twice a week. And driving is probably one of the most dangerous things we do that I think we all take for granted, myself included at times. And at literally any moment, like, your life is at the whim of everyone else on the road. I partake in a high-risk sport, show jumping. So like all of these things cross my mind probably at least daily. I'm also just surrounded by it at work.
Yeah, so you're way more qualified to be leading this conversation than I am. I'd be like, you should talk to your family. And that would be the extent of the the conversation I would be able to lead on this topic right now. So yeah, thank you for bringing us through this. I think it's super important that we do think about it, and not all of us are in the position of being confronted with it every day at work like you are, but that doesn't mean that we're not any further away from needing the information that we would gather from that conversation.
Yeah, and it's hard because it's a lot of medical terms and medical language and medical happenings that you're probably being confronted with at the worst possible moment, the moment that like you need to act on the decision, and that just makes it all more stressful. And so the other goal is just like introduce you to what this looks like so you have some idea before you have to do it. So let's start with what is advanced care planning. I have the definition per the National Institutes of Health, the National Institute of Aging. Advanced care planning involves discussing and preparing for future decisions about your medical care if you become seriously ill or unable to communicate your wishes. Having meaningful conversations with your loved ones is the most important part of advanced care planning. Many people also choose to put their preferences in writing by completing legal documents called advanced directives. So first, let's build the argument as to why goals of care, advanced care planning, these terms will be used interchangeably, is important. It's good communication. It leads to better outcomes, higher quality of care, reduced uses, hospital utilization, less aggressive actions, medical actions at the end of life. I think something like 80% of a person's healthcare spending is in the last like 20% of their life. And that's very like US specific. If you go to say like India, this isn't happening. Like the parents are just at home and they're dying at home. And a book I highly recommend is Being Mortal by Atul Gawande, which I think puts a lot of perspective on aging and dying, particularly as it is in America.
So you're telling me that by having these conversations, we will align on probably a lower level of intervention than the medical system would be doing by default otherwise. And if we haven't thought about it ahead of time, we would be subjecting ourselves to that higher level of intervention that we may not wind up wanting and would wind up costing more money and also sounds way more invasive.
Yeah, and it also decreases the stress on your families because At the end of the day, the decisions that are being made for you are what you would have wanted. So if you don't have these conversations and you don't indicate who's making these decisions for you, there's going to be a lot of stress because they're not going to be sure if this is the right decision, and they're going to be fighting because 3 kids want this and 2 kids think the other way. You could also die where you prefer to die. You could say, I'm leaving the hospital now and I don't want to go back. And you can get a legal order that you put on your fridge and it says, don't rehospitalize me. And then it also just reduces costs at end of life without increasing mortality. And this is really hard for doctors still. Physicians from higher spending geographic areas have less comfort in addressing end-of-life issues, treating end-of-life symptoms, and discussing goals of care, including something as simple as like resuscitation status, which we'll get to. We're not trained very well. I mean, speaking for myself, like we have patient simulation scenarios where like patient actors come in and we have a script more or less that we have to follow. Other than that, I don't think people are like, I just know that they're not very comfortable. For example, I have a patient now who has a devastating spinal cord injury. He's never going to walk again. And it took him like 4 weeks to land in our rehab unit where we're like versed in spinal cord injuries. Like to hear that he is not going to walk again. Like he was under the pretense that like he will heal and he will walk again. And that's so many doctors that he has gone through who have not set him straight.
So that's because the doctors are not trained in end of life. They're just trained in like, how do I fix problem and how do I fix problem at all costs? And then when they're in a higher cost of living area, they have even more resources to fix problem at all costs, even if it doesn't lead to the right outcome. Is that what you're saying?
Yeah, I would say that like I am not in this specialty. I very specifically chose my specialty because it's about quality of life. It is not about medicine for the sake of medicine, where I feel like a lot of hospital medicine, the cardiologists, the hospitalists, less so, but still to some extent, the kidney doctors, they're all trained to fix a problem. Even if that means we know that we're putting a Band-Aid on a problem that you're going to return to the hospital with in 2 weeks.
Interesting. And the doctors are okay with that? They like understand what's happening and they still do it?
Yeah.
I guess it makes the hospital money.
Exactly. Yeah. My specialty is very good at like comfort care, palliative care, which we'll discuss later, is kind of the specialty where that's their jam, end of life care. I think to your initial question, like doctors are most scared about taking away a patient's hope. And I work in rehab, so my goal is to make a patient as independent as possible despite the barriers that they might face. So like I know I will have the skills to recreate hope and recreate normal that most doctors are not aware of because it's not their specialty. But advanced care planning has been associated with a reduction in patient-reported measures of hope, and advanced directive documents completed by the patients have demonstrated changes in patient-related outcomes. So things we talked about, like dying how you want to die, where you want to die. As I alluded to earlier, this is your decision. It's if you are in the right state of mind, you are able to say, I want this, I don't want this. If you are not, it either falls to the person you elected or it falls to the next of kin. And we'll address all of those as we go. But it's important to have these conversations about what you would want in the event of XYZ with the people who you love and who you think would be put in the position of making this decision for you while you can. And if you can write it down, you should. What is honored is the most recent statement of wishes that can be verified. And beyond that, it's up to someone else to put themselves in your shoes. What does it look like if you can't make a decision? So let's say I'm calling you and I'm asking you, like, what was your grandmother's, like, cognitive orientation before the stroke, per se? I'm asking, like, did she know who she was? Did she know where she was? Did she know what year it was and what was going on? So that's someone who is alert and oriented times 4. You don't necessarily need to be times 4. You can be times 3 on and off, and that's like good enough as long as we like catch you making the decision at the right time. But the other thing is that someone has to have the capacity to make the decision. So they need to be able to communicate the choice, understand the relevant information we're presenting to them, share their reasoning about their decision, and appreciate the consequences, which can be positive and negative. Consequences are not necessarily negative. And when we're determining capacity from a medical standpoint, it's a decision by decision basis. Just because I say you don't have capacity to like state whether or not you want a blood transfusion doesn't mean you don't have the capacity to like go home instead of a skilled nursing facility, for example. Like it's a case by case basis, unless like you're deemed globally incompetent, which is a legal process.
Okay, so this is we sit down, we ask the person, what do you want? You ask them all of the various things, and assuming that they're at least 3 of the 4 forms of alert and oriented, as long as they are at least 3 of the 4 alert and oriented, then we'll document this, and that's the written proof that we will then refer to later when we have to be making the decision about those interventions.
Yeah. And so let's say that the person is incapacitated, they can't make this decision, they have no idea what's going on, they barely know who they are. Legally, like in terms of documentation, deciding who you want to make your decisions and what those decisions are under the umbrella term of advance directives. The durable power of attorney is designating who you want to make those decisions. I want Jackie to make those decisions. This is not a legal conversation. This is not on the this is not on the record.
I'm making all your decisions.
You would do a pretty good job. You have the mashboard after all.
Yeah, now that you have trained me in this conversation, I'm ready to go.
Yeah. And then your living will outlines what you would and would not want done. And each state has a different process. Sometimes you just need to sign it. Sometimes you need a notary, and then you bring it to the doctor and they put it in your chart and they update your code status and it's documented, and hopefully you have a connected electronic medical record that will follow you through your healthcare journey. And if you don't have advance directives, then it falls to the next of kin. And in the United States, this is the order that the doctors are going to. It's the spouse, the adult children, the parent, the adult sibling, and finally the grandparent. And then if they can't find anyone, they'll find the closest friend.
Oh, interesting. Okay, what you mentioned all adult children on the same line. Do they discriminate like oldest adult child, or they're just like all of y'all figure it out?
I think it's all of y'all figure it out, but I'm not too sure.
Okay, that sounds complicated. I see why we need to have this conversation.
Yeah, that's why I said like it can reduce tension in the family. And also like your advanced care planning, like you can change that at any time. It doesn't have to be permanent, but you have to make sure that like you update it through the proper channels. Otherwise, like the ex you had a really bad divorce with, if they're written down as your advance directive, like that's who's making the decision. Do you have any questions from here?
I'm just going to say back to you what I'm hearing, which is you explained previously why we want to have this conversation, how it leads to improved outcomes, lower costs, etc. How we have the conversation, there's a form called an advance directive or something like that, and then kind of state by state, you either you just need to like write it down, or maybe you need it to be notarized, or maybe you need to have it notarized and then also given to your doctor. And this is the process by which you're writing down what you want your end-of-life care to look like, and the doctors will respect it, but they will respect whatever your most recent documented advance directive is. And so if your situation changes, you need to make a new document.
Yeah. And it's like the most recent verified thing. So like maybe you didn't get your time to go to the bank or whatever, but like if you made it very clear to the people in your life and like everyone's on the same page, like that's fine too. We can roll with that.
Yeah, so this does sound similar to making a will, but it's a will not about like who's getting your money, but about like what happens to you. What is under the umbrella of things that are covered by this? Is it just like every medical intervention? Could it cover like I want to be cremated, or I never want to go to a nursing home ever. Like how expansive could this be?
I'm pretty sure it can be as expansive as your imagination wants. Typical decisions are like, do you want CPR? Do you want the chest compressions? Do you want a tube shoved down your throat if you need help breathing? If your heart or your lungs are like really crapped out, do you want like ECMO, which kind of takes them offline for a bit, like dialysis does for your kidneys? Do you want dialysis? Do you want a feeding tube? Do you want blood products? Those are the typical things. But it's whatever your imagination, whatever you can put in writing, like go for it, I guess.
Are there resources to figure out, like you're saying that list and I'm like, I don't know if I want those things. Like, I don't know how to figure out how I would feel in the moment about a feeding tube. Like, is this a conversation you could have with your doctor? Are there resources that people could pull from to get more informed about what the costs and benefits are of these various interventions?
I would have to look into it, and I will buff up the show notes as best I can. I will explain these things later in a little bit.
So Zoe is our reference. Zoe is our like guide.
All that being said, it's really hard to understand what you would be willing to do now as like an able-bodied 30-year-old versus what you would want in the face of like a devastating car accident or something. And, at this point in time, as a healthy 31-year-old, CPR, the outcomes can be pretty good. Getting intubated with a tube down your throat, that's reversible. Even if they have to put the hole through your throat eventually, that's also reversible. Dialysis can be reversible. It depends on the kind of injury to your kidneys. A feeding tube is totally reversible too. So it depends on like what you're facing and the trajectory of the decision, like of the prognosis. And that's really hard to know for anyone at any time, particularly when you're healthy, particularly because you're not psychotic like me and thinking about dying and tragedy every day.
I don't think that's psychotic. I think it just means you're good at your job. I do think about shareholder value on a daily basis, so.
Oh God, I think that's worse.
So who's the psychotic one now?
So I think the best way to do this is to walk through a hospital admission. Whoever you are, if you're being admitted to the hospital, they should be asking you your code status just to have on file because you're in the hospital, you're under their care, anything could happen. So the code status that they're typically referring to is if your heart stops, do you want CPR? And if you need help breathing, do you want to be intubated? And I want to make a note about CPR because at this point in my life, I would say, yeah, I want CPR and I want to be ventilated. But if they were to call about my hypothetical 92-year-old grandmother, I don't know that I would want her to have CPR. So I'm going to share another slide if I can find it.
Ah.
Yeah, that's alarming.
When I learned CPR, we were all like faking pressing really hard because you don't actually want to break someone's ribs. But I remember learning and being scared by the fact that we would actually be breaking the people's ribs in order to do CPR effectively. And that is what it appears that we were looking at, is a machine that was simulating the squishing of someone's ribs to the extent that they would probably be broken in order to engage the heart.
Yeah. So that was a promo of like a real device that we put on people if they need prolonged CPR that just does CPR for them. It's helpful if like they're in an ambulance or if it's taking a really, 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 really long time. And as you said, yeah, we need to be going 2 inches deep through your breastbone. Mine's pretty sturdy. Doesn't really have give of many millimeters, let alone inches. And we would be breaking ribs. And breaking ribs is probably one of the more painful orthopedic injuries you could have.
I'm so glad I never had to do this as a lifeguard. I'm squeamish. I would not have. Ah.
Yeah. And it's also not just about getting your heart started. The heart not pumping has consequences for every organ. You could get shock liver, your kidneys could go to crap, and you could need dialysis. And your brain will also be deprived of oxygen, which could lead to what we call an anoxic brain injury. It's a type of brain injury. And if you think of anyone else who's had a really tragic head injury, like their personality has changed, their attention has changed, they might be in a vegetative state after this. And being older, i.e. your 92-year-old grandma, doesn't make any of this. This makes all of this more likely, not less likely, because you have less physiologic reserve to recover for anything.
Okay, so yeah, what I'm hearing is that an intervention that we could survive easily as a 31-year-old could still be very devastating to somebody who's in their 90s.
And then intubation, they stick a tube down your throat. You are sedated. If you remember anything, it feels like a bad dream, and usually they can pull it out. It's not comfortable. I had one 35-year-old patient who had been intubated before. She came back to the hospital. My co-resident asked the code status and she was like, I don't want to be intubated. I've already been intubated. It was horrible. And at 35, she made that decision. And that was her right. And then let's say you're in the hospital and things are not looking great, and your primary team says they want to get palliative care involved. As I said, this is a specialty that is like their jam is end of life, but it's not just like ushering in the Grim Reaper. It's also like making sure that the care you are receiving, it's making sure you're getting goal-directed care. Like, as we talked about, like, what do you want? Do you want to take this chemo agent? Like, do you want to feel like shit and be nauseous and your hair falling out? Like, is that, like, will you have enough of a quality of life that this is okay for you?
Okay, so they could help navigate the conversations, or they just focus on, acting under the directive of the previously had conversations?
They help navigate the conversation so that the family is getting, and the patient is getting what they want. So palliative care is helpful for anyone who has a terminal or chronic illness. And just because you're followed by palliative care does not mean you're dying imminently. When they bring out the term hospice or comfort measures only, that's when things are looking a little more grim. Hospice itself is an insurance designation. It is telling your insurance company that we anticipate that this patient has less than 6 months to live. That way they qualify for different types of care that will be paid for.
Okay, so you got to be on your deathbed to get the comfort measures.
Yes. And at that point, once you are comfort measures, once you are in hospice, you are agreeing to not receive any life-saving measures. You are not going to get CPR. You're no longer going to get chemo. You won't get intubated. In some cases, they might give you an antibiotic if it's like a UTI and it's really just for comfort. But the goal is to make you feel comfortable. They might give you some diuretics to get edema off. They'll obviously give you pain meds, but nothing they're doing is hastening your natural death. It's just making you comfortable as you die. So they're not overdosing you on morphine. They are giving you more morphine than, say, I would give you in the rehab unit. But the goal is not to OD. The goal is to keep you comfortable as you do die. Because we all die.
Mm-hmm. Are there situations where people don't go to hospice, but they should, and that's something that they could have navigated ahead of time with the advance directive?
That would irritate me to no end during my intern year, is I would say, this patient needs to be CMO. We're done here. Everything we're doing here is futile. We should withdraw life-saving measures and make them comfort measures only, CMO. But that's easy for me to say. I have a 29-year-old in my first year as a doctor who has not experienced any significant death in my life. And it's not my decision to make, and it's not my grief to bear, and it's not the guilt that I may or may not be feeling.
And so the people who were pushing back against that was the family and the patient?
Usually the families, because the patient's incapacitated at that time. I did have one instant where it was the patient. And all within their right.
Mm-hmm. Yeah, but all the more reason to have the conversation ahead of time, because if the patient wouldn't have wanted that and the family was insisting it because they were in denial about what was happening, this is the situation where you could go back to that advance directive and say, actually, no, they didn't want to have all of this.
I don't actually know what kind of advance directives we had in front of me, but the most frustrating was when it was the families who were like really were in denial. That's what it was. They were in denial about losing dad. When it's, the 30-year-old patient with pancreatic cancer and now he can't breathe, but he has a 2-year-old at home and he just he wants to hold on a little longer. I have so much more sympathy for that, as terrible as it sounds, because I can see how much pain your grandma is in or your 83-year-old dad is in, and I can see that this isn't going anywhere.
Yeah, it's not giving the dying patient good quality of life days. They're not able to be there in a meaningful way. You're not getting your dad back. So by insisting on continuing to keep them alive with very invasive procedures, you're probably actually making the end of their life more uncomfortable and more painful. And you're denying them the dignity of being nope, this is it. We're going to go to hospice. We're just going to make you super comfortable and give you a pleasant exit.
Yeah, peaceful. And it's the process of dying is kind of a 2-year process, and it accelerates towards the end, as you would expect. And I'm thinking about this because it's a conversation I recently had to have. It's not just that they are hospitalized more often. They are not healing as well. They are going to be sicker from the same thing for longer. And then they're not going home. They're going to a nursing facility where they're going to have 15 minutes of attention every few hours. And then they're going to be getting bed sores. And that's also going to get them sick because that's a port of infection, and they're going to be back in the hospital. And so it's not like they're going home. Even if your dad's quality of life is defined by the fact that he can sit in his recliner and watch the game on Sundays with his family around him, he's not really going to get that. He's going to be stuck in this hospital healthcare purgatory,
Yeah, sounds really impactful then to be able to give somebody the hospice intervention at the time that it would have an impact. And so having these conversations when someone's not on death's door and you're not with the heightened emotions and just afraid of losing your dad, and it's actually more of just he told you what he wanted and you can give that, and there's a lot more I imagine there's a lot more peace in that moment too, of being this is what he wanted.
Very much so. Yeah. So to summarize, you're going into the hospital, you should be asked your code status. And listen, all of this is me waxing and waning on my experience. This is not telling anyone what to do. I just kind of want to give you a primer so that you're not caught off guard. CPR and intubation, these are not little things, but as a young, healthy person, there's things you can bounce back from. It's when you're talking about your frail little grandma that I want you to take pause about considering CPR and about intubation, because it's harder to pull someone off then and get them breathing on their own then. And then, if things are not looking good, you have a terminal illness, grandma's just really frail and actively dying. This is when hospice, or at least palliative care, is an appropriate step to take so that the goals, the values are all understood and can be acted on. And that might mean hospice, or maybe grandma doesn't qualify for hospice yet and you have more time with her. Every situation is different. Another way to look at this is what should you be doing now as, 30-year-olds who in another decade or less will start having to take care of our parents, and we are going to become the generation between our children and our aging parents. When you're typically not thinking about death, what should you be doing now? You should be talking to your parents about who they want to make the decisions and what those decisions look like. You should be encouraging them to get them legalized, formalized in whatever process your state requires. And it's just generally having detailed discussions about your values and your wishes and your goals and what makes your life worth living. Because that's what these decisions come down to. If I can't go out and run, then this isn't worth it to me. Or I just want to be able to be surrounded by my family and enjoy a Sunday football game. Like, it's different for everyone. I would also say that if you are young and unbothered, you should learn CPR because CPR can save lives. When it's done effectively, it can save lives. When you get admitted to the hospital for any reason, you'll be determining code status. And you can change all of these decisions, including your code status in the hospital, at any time. And then if you get diagnosed with a serious illness, you should get palliative on board because they can help you navigate this. They are like a translator for all of these medical decisions and what it means for your life and whether that's something you want.
So do you recommend that I, as a healthy 31-year-old, get an advance directive now? Or is this just a conversation I should be having with my parents? Like, who is under the umbrella of benefiting from pre-thinking about this?
Probably everyone. My recommendation would be to have these conversations with your parents and your family. I don't know about like whether you or I, as childless 30-year-olds, need to put anything in writing. Maybe designating who at this point in your life you want to make your decisions would be most appropriate. Right now, I believe it's going to your parents, if I refer to my notes. Yeah, it would be going to your parents. And if you're okay with that, then you don't have to do anything. If you want it to be someone else, then that's worth putting in writing. And then generally, like, based on, like, the one conversation I had with my dad about, like, do you have a will? When I was, like, 13, he's like, yeah, we did that when we had kids. Like, I think it's when you start to have kids that, like, these things start to, like, what's your word? Marinate.
Okay, so what I'm hearing is my parents definitely need to have this. I should have the conversation with them. For myself, at this point in my life, it's not necessarily critical, but in having the conversation with my parents, I'll probably start thinking about it, and I'll probably be like dropping tidbits to them of like, oh, I'm comfortable with this, I'm not comfortable with that, but it doesn't need to be a formal thing. And then when I reach a point where I have dependents, that's when I should really get all of my finances and advance directive and like all of that stuff squared away. And then even once they're squared away and I have the kids, I should probably still revisit them at any major life milestone. Like if I get married or get divorced, or if my health situation changes, then at that point I should be re-initiating an advance directive, like sit down and re-ask myself how I feel about these things.
Yeah, I think that's exactly it. The other, like, tangentially related recommendation I have is, like, once you're, like, 50 and, like, you're an empty nester and you're, like, looking to downsize, the next house you should get is, like, a ranch with as few steps to get in that is as accessible as possible. That is your best bet of getting home after any major injury.
Man, my parents just bought a new house a couple years ago and it is not a ranch.
And the most dangerous room in the house is the bathroom. So make it as safe as possible.
Oh, because it's slippery?
Slippery, hard, cold. So those are just like random tangential recommendations.
But yeah, it makes sense. Okay, can I ask you a few more questions?
Absolutely.
Okay, so what if you're in a situation where somebody set up an advance directive and then their situation changed to the point that what they wanted for themselves is very bad? I'm thinking of a grandmother that I know who said, I definitely do not want to leave my home, but she's now in a cognitive situation where, like, she is not capable of taking care of herself. Like, what do you do in that situation?
That one's hard. I mean, you hope that she has the means to hire private 24-hour care. Otherwise, I mean, you, like, as a doctor, we can't send that patient home. Like, there are situations where, like, a patient, he can get around, it's ugly, it might not be the safest thing, but he can, like, we can converse about the consequences and he can still go home against medical advice, as opposed to going to a skilled nursing facility. That's not the situation you're describing. And at that point, I have not been in that situation. I don't know. I think it's just like, yeah, they hope she has the means, or like, fuck, like, we can't keep her in the hospital. Like, it's not necessarily a safe place either. And like, other people need these resources. So you either have to make it work as a family and like get grandma to one of your houses and take care of her and have round the clock care, or
what is that alternative?
You can't execute her.
Sorry, Grandma. You can't live at home anymore. That's it. It's been nice knowing you. Okay, so then is that a situation where you can, like, I don't know, wrest control from her and say, like, no, she wanted that, but we're not giving it to her?
Yeah, because she's not in control. Like, she's confused. She doesn't have the capacity to make these decisions. So naturally, it's going to the next person. And you know what she wants, but it's not feasible. And, like, she's got to go. You know, like, you either have to rally and make it work for her, or she's going to go to a nursing home, I guess. That's me thinking off the top of my head.
Yeah, yes. But then you probably need to go through the process of being like, she's not of sound mind to make this decision for herself. How do we...
Yeah, but that's fine. That's something a doctor is able to do. When you're talking about, like, competent, like, capacity, that's the assessment the doctor can do. Competency and, like, globally, this person is not in charge of their life anymore. They're in a conservatorship. That's a legal decision. That's a process. But if we're talking about dispo planning and, like, grandma clearly can't go home and we know what her wishes are, it's just unfeasible. The family can't rally. The family doesn't have resources. The shit is expensive. Like, we did the best we could.
Yeah, but that doesn't sound like it's a decision that a doctor makes blindly. It's like if I were a person who had an advance directive that said, I really don't want to go anywhere other than home, like, that wouldn't be ignored unless there was a situation where, like, I did not have the capacity to go home, and then someone would step in and be like, hey, like, you're not in sound mind, you can't be making this decision anymore, and we have to do something else for you. Is that what I'm hearing?
Yeah. Or if, like, this happens when you're, like, let's say I really don't want to go back to the hospital, you can get, like, a do not rehospitalize me order. I don't actually know what that looks like on, like, the side of the EMS who are calling you, like, answering the call to come to your house. I don't know if they just, like, put you back in the bed and, like, walk away. I don't know what happens, but, like, that is a legal document signed with a doctor, because I didn't get into, like, a MOLST, which is, like, a medical order. It's like a neon sheet of paper that says do not, like, that follows you outside of the hospital, so that, like, if the EMS were to come, they know not to give you CPR. They know not to intubate you. That's for, like, if you're really sick.
Yeah. I'm hearing that you do have a lot of control over your situation. It's not perfect, but by having the conversation ahead of time, you can do a good job of managing your end-of-life care. But also, if you're in a situation where what you wanted isn't feasible anymore, then it'll probably go back to the drawing board a little bit. And if you're the family member of the grandmother who can't take care of herself and she's insisting on taking care of herself, you do have some recourse that you can, you know, make sure that she's not going to a completely unsafe situation. But in general, if she has a, you know, do not resuscitate, do not return to hospital, like that sort of thing, like, me as the family member, like, I have to respect that that's what she wanted.
Yeah, because assuming those things were signed with a doctor when she was of sound state and mind to make that decision.
Oh, but we have a fear of death, so we don't like talking about it and thinking about it and putting it in writing.
That's why we're having this conversation as the people we are.
Yeah. Okay, do you have any advice for how I broach this conversation with my parents? Because we've talked about their will, but we have not talked about end-of-life care. And I feel like when I have mentioned it to them, they're like, ah!
I don't. Like I said, I'm not putting on any airs. I haven't had this conversation with my parents either. And I'm also not, like, great at confrontation. It's something that's, like, the major part of my training right now. Second to the medicine, it's the, like, art of medicine, which is delivering bad news and problem solving. I wouldn't just be like, so do you want dialysis? Like, I feel like, you know, you watch The Pit or whatever with your parents, or they're telling a story of, like, something terrible that happened to, like, the neighbor's kid. Like, there's an entryway there. Or you just be like, hey, I'm, like, really nervous about this, and a solution is that we talk about it. Do you mind if we set aside some time to talk about it?
Yeah. I mean, you mentioned the book at the beginning of the episode. I feel like, hey, should we do a book club? Like, I read this book recently, and it really made me think that these are conversations that aren't that scary, that they're really important, that we should be having. Like, can we, maybe that's a good approach.
Yeah, as extra content, as community building, we could have that book club with Being Mortal. It is because of this book that my mother-in-law joked that we are going to build a, like, assisted living facility program in our town. once she retires. And I think, like, there's a chance it could happen.
I'm glad she's thinking about it and read the book.
Unfortunately, she's been forced to think about it in the last 3 years, but yes.
Yeah. Well, I think it's one thing to think about it for your parents. It's another thing to then take that information and be willing to apply it to yourself. So I feel like, yeah, she was forced to think about it in general.
And she did. Like, a nice advanced assisted living facility, a place where it's like you're buying into an insurance program. My grandmothers were in this. It's like you start and you're still independent. So you have your own little condo in this community. No one's really coming in and checking on you. And then something happens and you're not as independent anymore. And it's like an assisted living facility. And then like your memory goes and they have memory care there and they have a hospice there. And it's like an insurance that you pay for, like you pay into. And my grandma lived there for like 20 years. These places are expensive. So sorry. That's the privilege. But they also have really long wait lists. And my in-laws have put themselves on this 8-year wait list.
Good. Yeah, that's great.
Which I am very grateful for, because the other conversations that are really difficult as part of this is like, mom and dad, like you can't live at home anymore. This is too dangerous. Or dad, you really can't be driving anymore. Like those are like the gradual reduction in independence is really hard.
Yeah. Yeah. Because what do you do if they don't live in an area where they can get around anyway, other than driving? Then they got to like have friends. You got to pick them up. I don't know. You got to get a lot of grocery delivery. But yeah, that's a hard conversation. I feel like we could have a whole nother episode on how do you afford this? What does end of life look like?
We would need like a case manager, someone else who like actually works on this. What I do know is like if you do not have means, like if you are like covering this through like Medicare, so like the government sponsored healthcare, like they are looking at your assets and you have to like, and they are taking everything you own so that that's how you pay for it. Like it's devastating.
Oh boy, yeah. We'll have to cover that in another episode. What do you do? But yeah, okay. I feel like I learned a lot. I feel like I'm marginally more prepared to have this conversation with my parents now. I definitely understand the value of having it and, what to do after we have it, like what to look up, how to document it. Anything else I should be learning, or are we ready to talk about what our 20-year-old selves should have learned from this?
I did we're like short on time now. I plan to like take you through, there are a couple organizations. This is all in the show notes. One is called Prepare, I think. Yeah, it's Prepare for Your Care. And they have put together resources by state to walk you through making this decision so that at the end of the day, you have the form that you either like take to the notary or you take to your doctor. And so that was something I was going to walk through, but we could do that as like an extra content. It doesn't necessarily have to be now. So that's something that I'll say, put in the show notes. There's also a link I found that takes care of the like financial asset, trust, estate side of it all, which like, I don't know. What was your question?
Oh, no, that's helpful. So yeah, those are the next steps, things that we could do. Talk about resources that people should check out in the show notes. My question was like, can we talk about our advice for our 20-year-old selves?
Yeah. What do you want to tell your 20-year-old self?
Oh, I have to go first?
I can go first. For me, I think I didn't have a lot of fun in my 20s, and I wish I did have more fun because life can literally end at any moment. And I think the ironic part of wanting control is like the assumption that like you want to stay alive, but we are all going to die. We don't know when or how at this point. Maybe you're diagnosed with like some horrible disease and you kind of know, but like even then, like if you're given a diagnosis of cancer, it might not kill you. You might get hit by a car before it kills you. Like you literally never know. And so I just wish I had more fun.
I wasn't expecting that advice, but that's great advice. I think that is a great conclusion. Yeah, you only live once, YOLO. I'm having a lot of thoughts. One of my thoughts is that as a 20-ish-year-old, I was a lifeguard and, I learned CPR. We went through all the trainings, but it was always just like hope we never have to do this. And I'm glad I know how to do it, but I don't think I took my job seriously enough. I think, like, luckily nobody ever drowned on my watch. I was always just watching pools that nothing was happening in. But I don't know. I don't know that that was the right job for me. I think if there had been something, I don't know, I would have learned a lot about myself, but I don't know that I'm not a doctor, and there's a reason I'm not a doctor.
Maybe you would have been if something had happened.
Yeah, something would have happened and I would have gone, wow, this isn't too bad.
Sally's teammate broke her wrist playing soccer, and that's why she became an orthopedic surgeon. So
Wow. Okay, yeah, maybe that would have happened. But as of right now, looking back on my 20-year-old self, I'm like, ooh, did you really need to be a lifeguard? Maybe you could have learned those skills and then, like, done something else instead. Like, leave the hairy healthcare thing to people who have a better constitution for it. But I don't know if that's the most widely applicable advice, and I don't, like...
It's what comes to mind. Like, that's okay. There's no rules. It's like, this is about... The 20-year-old self-advice is about you.
Yeah. Yeah. I mean, I think the other thing I'm thinking of is the person we were friends with in college who wound up dying a couple years later in the car crash. And, like, that was the first person I know who died who was young and I, like, knew personally. And we were close friends, and that really threw me for a loop. And so I guess my 20-year-old self, I would say, like, hey, like, not all of these people will be here. Like, appreciate them.
Yeah. Okay. Well, I hope I didn't completely ruin your day.
No, I think it's good to think about these things. I think we have such a fear of talking about death and admitting death, but we don't have to. Like, that was when I was in Mexico over the weekend. That's definitely one of the things that struck me is, like, we went to a history museum and we were learning about, like, the ancient Mayans and like all of their culture and the Day of the Dead and all these things. And I'm just like, this culture knew how to talk about death. I mean, they, like, also sacrificed people, so they had a different relationship with death than we do in a lot of different ways. But it just struck me that, like, death is not something that we talk about. It's not part of our culture. It's not something that we put in our museums. It's not something that we celebrate. We don't really, like, honor or think about. We don't have rituals around our dead family members and the cultures in Mexico I was learning about did. And yeah, so, like, I don't think my day was ruined. I think it's, like, making it less scary. Like, obviously it's sad to think about someone dying, but it feels like it's not going to be this, like, completely unknown, like, what the hell is happening? I don't know what the options are. Like, we can, like, get ahead of that by, like, having conversations and doing our research and filling out paperwork. And then, like, when it does come for us, because it will come for all of us, then we can have a much better understanding of, like, no, I thought about this. I know what's going to happen. I know what's not going to happen. And I'm doing it in a way that feels right for me. So I feel, ironically, more at peace than I did.
Yeah. And I think it's, like, the best gift you can give to your family is, like, these are the, like you said, these are the decisions I want. You don't have to make them. Like, I want you to stay in each other's lives. I don't want this to cause an unbridgeable rift between you all. Like, I can be at peace, and so can you.
Mm-hmm. Yeah, this was what I wanted. You can feel comforted in knowing that I'm getting what I wanted, even if it's not what you would have chosen for me, or even if it looks hard or painful. Like, end of life is hard and painful, but I'm doing it my own way.
Yeah. And so, for once, Dr. House is wrong. Like, there can be dignity in dying. And I think that's, like, the greatest privilege a family could have.
Mm-hmm. Yeah, well, very important to learn about this today. Thank you, Zoe.
Thanks for listening. Now it's time for the obligatory sign-off, except for the part where we thank our amazing producer and editor, Jay.
Jay, we could not have done this without you. But also, listeners, we couldn't have done it without you either. So please like and subscribe. You can find us on all of your favorite podcasting apps.
And all of your favorite social medias at AfterMashPod.
And your least favorite social medias too, for the record. And if there are any topics you would like us to cover, leave us a comment, slide into our DMs.
And until next time, this is Life After MASH.
Goodbye.
Goodbye.